All right, from last class, go back and take a look at initial symptoms of MS presentation.
Weakness at night. Sorry, asking a question, sir?
Am I asking a question? I don't know if he's joking. Look up MS flare, treatment, and risk factors. Go back and look at your spinal tracts again. I think we talked about that enough, but specifically I'd take a look at your dorsal column. Let me see here. First try. Take a look at ADEM, presentation and treatment. Take a look at your upper and lower motor neuron findings. So there's a bunch of slides on that. I think if you just look at the one that compares and contrasts upper and lower motor neuron lesion findings would be good. Look at your myopathic gait. Look at ALS presentation. Look at Brown-Séquard syndrome. So everybody's like, did we talk about this stuff? Isn't it crazy? Yeah. This was last class. Like when I walked in around this time, this for the seniors right about now, I walked in and the back row was like, have we learned anything in this class? And I'm like, damn, that sucks. Y'all's test is on Friday. Didn't really hurt my feelings. But I'm like, oh, we've been going over some stuff. So yeah, we went over this Friday, but you guys were farmed up. I get it.
What was the last one you said?
Brown-Séquard syndrome.
Brown-Séquard.
Yep. It's a spinal cord injury. And then look up, I don't know if I have a question on there about psychogenic gait, but take a look at that. Just, I've written down psychogenic gait. I don't know why. And the plan will be tomorrow, do a better review. So if you haven't been paying attention to the last couple of those, and we'll just do that together and iron out any questions that we might have. Test is being previewed by Colonel Peter, so we'll see what she says. Maybe she says, no, I don't think this is a bad one. It's probably gonna be easy. It's good. All right. You guys want to just go? Want to run through this stuff or what? So we'll talk cranial nerve disorders today. So if we're going to talk cranial nerve disorders, what are some things you guys are going to want to know before we get into this lecture? Oh my God, dominated, crushed it. So I'll wait till tomorrow, or we can tell you now. Like just knowing your cranial nerves, which are motor, sensory, and both, will get you like a couple points on the test. So I would take a look at that if I forget tonight. All right, well, kind of open it up to everybody. What do you guys think? So what comes to mind when you think cranial nerve disorders? Anything specifically? Palsies? Yeah. What else? I'm sorry? Motor sensory deficit? Good. Anything else? Anybody ever have one of these or know somebody that's had a cranial nerve palsy or deficit? You're what? Oh yeah? Nice. Let's call you up front and just like zoom in on your eye. These are pretty fun to find. I mean, usually people say Bell's palsy or facial nerve palsy is the one that comes up as the one that most often people seem to remember or know. Why do you guys think that? We haven't even talked about Bell's palsy, but the unilateral facial paresis, right? So half of your face doesn't work, so the patient kind of comes to you guys. Yeah. An immediate thought would be, yeah, like consider that in your differential, especially in the ER, right? Like, are you stroking out on me, or is this something else? And there's some things we'll talk about. It isn't always 100%, but that can help us delineate between the two, right? So I've had Bell's palsy come in. My last Bell's palsy guy was overweight. He was like 60s, overweight, uncontrolled diabetic, and his blood pressure was like 210 over 160. And everything felt like a Bell's palsy. You think I still spun his head and worked him up for a stroke? Oh, hell yeah. I'm like, my attending's like, oh, it's classic Bell's palsy. And I'm like, you look at his blood pressure. He's like, oh yeah, good job, right? And I was just like defensive medicine, but sometimes you gotta do that. All right, let's see if I can glue myself up here. Maybe it'll keep me on task. Probably not. All right, it's our ELO, or our end learning objective there, so end state, and then we'll go through these each, right? We'll go as fast and slow as we need to. Some of these I think you guys have seen before. Do any of those words look familiar? Okay, words. Words, yeah. Some of them, I feel like you guys have had some of these HENT, but I might be wrong, or, and that's okay, that's good actually. That's rehashing some of this stuff. So. Yeah, so just what I said a couple minutes ago, you gotta know these. If we're gonna navigate cranial nerve disorders, you gotta know the cranial nerve. So however you come to grips with this, if you have a mnemonic, that's great. If it's a dirty mnemonic, I don't care. But you gotta be able to write this down and articulate. And I think, I might just ask you guys which ones are both, but I can't remember. But you gotta know it anyway, so more to follow. All right, visual system, 2, 3, 4, and 6, right? So this is just, I'll make this make sense in a second here, but this is starting from the top of that screen, your right and left hemifield, that's our external world, the external stimulus around us, how it's interpreted by the eye, right? So your nasal goes temporally, and flip that, so temporal portion goes nasally. And then when it goes back to the back of the eye, to the retina, really we just want to be able to track that back to the optic disc, to the optic chiasm, optic tract, and then all the way back to our occipital pole, which I think I said the other day, I think that's a weird design flaw, but that's the way we're made. That's just a long way for your vision to travel, I think. So, okay, these next couple slides are going to show us what happens if we lose or knock out a portion of our optic nerve at any given point along the visual system, okay? So I get it. I took this from my predecessor, but I like the red and blue one better because it's sharper and crisper for me. The black and white one, it's really just redundant and showing you the same thing. So if that's confusing you guys, I apologize. The test will have one question on this, and it'll be from the black and white one. So I don't want you guys, and I'll tell you which one it is because I don't really care. I want to make sure you guys get it all right. But more important to me, right? So more important to me is like if your patient's coming in, and we're going to break these down. See all these different numbers right here? We're going to talk about like, well, if your patient comes in and they have this, right? They can't see out of their right eye. It's completely gone. We got to consider a lesion. This is completely dissected. Versus 2, 3, 4. Take a look at 5 when you're studying a little bit harder, 4 and 5. How do I get this from my patient? How do I get this? So this is what your patient's complaint is. Of course, they're going to tell you, I can't see. Visual fields, right? So you're going to do visual fields, or you guys sometimes, and visual fields work great, but sometimes when you're trying to delineate between like, specifically like 3, 4, and 5, like it gets kind of touch and go there, right? So you can just have them kind of draw like 2 circles and shade where they can't see, and try to have them almost replicate that to make it make more sense to you. Ultimately, if I'm concerned about something in their visual pathway, and let's just say all things being equal, I'm in the emergency room, like what am I going to do for this person? Neuroimaging, right? So I'm going to image their head, and hopefully we'll find something, and if not, and they're still having visual, like transient visual complaints, I'm going to admit them for like an MRI opto consult. So I'm not just going to be like, oh, CT didn't show anything, good luck with your one eye, like get a patch or a virus. Like it doesn't work like that. So, but for kind of where we are right now, I want us to think about this as a kind of, pun intended, right, black-white construct with the one on the right, and if we have lesions at those numbered areas, what it would present with for your patient. So this to me makes a little bit more sense, how we kind of extrapolate the numbers out to the left, right? So you can see with 1, you get a horizontal defect. You can see in that right eye is knocked out. That could be the whole eye too, but bottom line is in the back of the retina. And folks may come in and say there's like a shade being pulled over my eye, right? You can see there, number 2, complete desiccation of that optic nerve, right? So that's right optic nerve being cut, your complete right eye is gone. That should just make sense, right? 3 at the optic chiasm, so now we're getting that transverse desiccation, and that's going to get you a bitemporal hemianopsia, right? Does that make sense to everybody so far? Okay. And if it doesn't, like, chase this up, right? So if I took my weird slides from the other day and just took a knife and cut down this, and I put that scalpel up there, like, trace these red and blue tracks, and you will come all the way up here and into the external stimulus of the world and see that you will not be able to see temporally on this individual. So, okay. So same for 4. If you're not, again, if it's not making sense, chase it back. But I'd argue that 3 and 4 may be hard to delineate just based off the anatomy. But the textbook would say that I'm wrong and don't get a vote. So 5 is a classic one that's always asked on boards and probably will be asked to on Friday morning. But this is a homogeneous left superior quadratic defect, or pie in the sky is what it's always called, right? I had this on my PanRe LA. I think that's why it shows this as a question. And I've just been too lazy to change it. And then I'm just like, you guys should know this one. So, but again, end state for this is for me, if you guys look at that diagram and where any of those numbers are, 1 through 6, and you can kind of trace it forward and figure out potentially what pathology your patient may be experiencing. Does that make sense? And I'm saying the same thing again and again. You're like, it didn't make sense the first time. Stop saying it doesn't make sense. All right, and then 6, you guys can see there, back towards the occiput, right? So left homogeneous hemianopia as well. So I think 5 and 6, when your patients are kind of going through that type of visual discrepancy and they come to you, it's really difficult to delineate those, so I wouldn't get too wrapped up around the axle of like, I won't, no, I'm just going to choose 5 for the X, so there you go. What was I going to say? Jeez, in and out. I don't know, it'll come back. Extraocular movements, so LR6, SO43, that should hopefully, like, you'll remember that wherever you go for the rest of your life. Unfortunately, you'll be sitting here 20 years from now and you'll just regurgitate it and be like, whoever taught you that did a good job implanting in your head. So, lateral rectus is which? Good. Superior oblique. And everything else? I know you guys gotta play along sometimes. I know it's tough. Having a general idea of the pupillary pathway, so you guys can see there, light impulse travel up the optic nerve, divide at the chiasm, arrive at the pretectal nucleus rather, and that's your afferent pathway. Efferent signals sent via cranial nerve 3 to cause direct and consensual constriction. So what if I shine this light in this model's right eye? What's the left eye doing? Is it doing the same thing?
Yeah.
Okay, good, right? And if it's not, could that be concerning?
Yes.
Good. All right. So when you guys are doing your RAPD and flashlight swinging, looking at your eyes, right, and you look at the right eye, if you shine it in the eye, and it constricts, then dilates, right, reacts, accommodates. Same thing for the other eye, because the eyes are yoked, correct? If they're not, is that a concern?
Yes.
If they're not, and they just came in from like an MVA, or like were blown up or hitting the head, is that a concern?
Yes.
Yeah, it's a big concern. Good. Historical factors consider, right? OPQ-RST, sudden onset, usually implies a vascular event or stroke. Slow evolution, so inflammatory or neoplastic disease. So what's an inflammatory process we talked about that involves the eyes? Yeah, diabetes is always going to be a good answer. What else? MS, good.
CMV
Yeah.
inflammatory?
What is it?
CMV?
Cytomegalovirus?
Yeah. Is that inflammatory?
Yeah, I think your partner's just totally out. Yeah, there you go. Welcome back. You alright? You're gone.
No, I was here.
Oh, you were? I'm gonna call BS on that one. If you feel confident, you stick with that. So. Alright, transient or recurrent systems, you guys see there ischemia, MS, myasthenia gravis was the other one I was thinking about, and then diplopia, inability to maintain a concave gaze. Alright, what are we gonna do for our visual complaints?
Check them out.
Visual acuity? Yeah, check them out. Visual acuity, but what else? You guys don't have to name it.
Cranial nerve test?
Yeah, so absolutely. You can get a cranial nerve test. Absolutely. Cranial nerve 2 through 12 grossly intact, right? Why shade on a cranial nerve 1? I don't know, just the way it is. So visual acuity, color testing, visual fields. You're going to look, right, lids, extra ox, position alignment, pupillary reaction, so you guys can see there. But wait, I don't have a wall chart for them to read. What are you going to do? Yeah, exactly. So give them something grossly to read, or you have a pocket smell them because you're badass. But we're just never not going to do a visual acuity, right? You understand that? If I asked you that as a test question on Friday, like when do we not do a visual acuity, would that be a fair test question?
Yeah.
Yes. All right. When the person's blind, it doesn't matter. All right, cranial nerve 2, we'll talk about some monoocular visual disorders, specifically 3 of them: transient monoocular blindness, optic neuritis, and then giant cell arteritis. Okay, so transient monoocular blindness is our first monoocular visual disturbance. It's also known as amaurosis fugax. I have maybe I've mentioned this like before, just incidentally, but this is sudden transient loss of vision in one eye. This is usually decreased blood flow to the retina, likely a embolism. Right? It's like a curtain coming down over one's eye. Careful, right? So that's also could be a detached retina, but I would definitely keep that in your differential. If you had a detached retina, consider a transient monoocular blindness or amaurosis fugax, okay? Patient has to have a complete evaluation for a TIA, which is a transient ischemic attack or a mini stroke and or a stroke, right? So if your patient comes to you and you're working in the ER, or if you're working anywhere really, and they're like, hey, I've completely lost vision in my eye, like, you know, and they're like, well, it went out, it came back, like, you still have to work them up for a stroke, okay? You still got to work them up for a stroke. That could be a sentinel shot, like a warning of something bigger coming. It probably is, to be honest with you, so. All right, kind of hard to see, I guess, unless, no, sorry guys, I'm going to the side again. So you can see this hole in horse plaque here, up in the middle of that bifurcation.
Let's touch that again.
There you go. Thank you. Thank you. But what is that? So that's a piece of plaque that came from where? Yeah, like clogged arteries, hard work, I don't know, poor diet and exercise, genetic predisposition, I don't know. But if there's a little piece of plaque that did that and came up to the eye and caused some blockage of blood and change in vision, do you think there might be more of that plaque downstream?
Yes.
And where do you think that's going to go?
The eye.
Yeah, hopefully not, but unfortunately, Occam's razor says it's going to go up to the head and stroke them out. We just got lucky that it happened to be small in the eye at this point. So, and especially when you look at them, like I said, these are my patients who, you know, I alluded to my Bell's palsy that had blood pressure north of 200, right, systolic. Like that high, consistent blood pressure banging on that atherosclerotic plaque is eventually going to cause a problem for these folks. All right, second one is optic neuritis. What do you think that is? Oh, it says it right there. You might ask. I was going to have you guys break down the word, but inflammation of the optic nerve. Good. Think MS. So again, think MS for these folks. You see your essentials of your diagnosis. Subacute, unilateral, usually the vision loss develops over a few days, okay? More severe visual loss associated with low serum D. Did we talk about low serum D for a risk factor? No?
I don't remember, no. You did now.
Did we? I thought I mentioned it for a risk factor or something. I'll check in the break. All right. And then I think I asked you guys who's low serum D, and everybody's like, we all are, right? Did I hallucinate? Did that happen?
It happened.
Could have happened in a dream, guys. It's kind of weird. Yeah, so well, you guys got way more going on than I do, but I think I mentioned something when I was telling you guys, like in San Antonio, it's crazy because we have all this sunshine, but nobody goes outside and is exposed to it. Unless you're an IPAP and you're frozen, and you guys are like chameleons, like sunning yourself out there. I'm like, what are you doing? They're like defrosting my hands. I'm like, oh man, I feel you. So, but I think what I need to confirm is that low serum D is going to be a risk factor for MS, which is just going to tie into all this. So, anyways, pain exacerbated by extraocular movement, so retrobulbar pain, so pain behind my eye, right? So there's a lot of pain behind my eye, which should tell us we have concern for swelling of that optic nerve. Okay. All right, retrobulbar neuritis is characterized by a normal fundus, right? The doctor sees nothing and the patient sees nothing. So you guys look in the back of this person's eye, what do you see? Kind of looks good, right? Maybe you see some blunting around that, that whole cup to disc. I don't know. I'm hallucinating. That looks pretty darn good to me. I don't see any cotton wool spots. I don't see any AV nicking, blood and thunder, nothing. So, but your patient cannot see anything either. So, work up. So your patient comes in and says, I can't see out of my left or right eye. So we're probably going to want to talk to ophthalmology, right? So MRI of the head and orbits. So treatment, if it is optic neuritis, steroids are going to be helpful, right? So if the optic nerve is swollen and getting larger, it should make sense that, I don't care if you know methylprednisolone, solumedrol, decadron, it doesn't matter which steroid, but a corticosteroid should suppress the immune response and help with the swelling, right? So. Prognosis, MS may develop within 50% 15 years, 50% within 15 years, yeah, I said that right. And then risk factors, female and multiple lesions on the brain MRI are going to be a worse outcome, okay? So take away optic neuritis, comes in, can't see, we're going to work them up. I'm going to work them up for a stroke 10 times out of 10. I'll probably get a CT, CTA, it'll be normal. My visual acuity is normal, visual acuity abnormal, but my ophthalmics exam will be completely normal. I'm still going to contact ophtho, admit them for an MRI, and get them on board. They can figure that out. But plus or minus, I would 100% hit them with steroids early. So, yo.
Is the MS due to the optic neuritis or to the
Low vitamin D is a risk factor for developing MS. The optic neuritis is secondary to that gliotic formation from MS, usually along that optic tract. So, yeah. So, it's sometimes, if you remember, we showed you guys, I showed you it was a busy slide. It had all the MS findings, and I said, hey, after the first 3, don't even worry about it. Does anybody remember the first 3?
Like weakness by the end of the day.
One of them was eye pain, right? So it was like sensory changes, eye pain, but this is kind of showing you the eye portion of MS. I don't know why they kind of give it to you with MS. A little bit harder, but we're not kind of going into our cranial nerve. So. Right, giant cell arteritis, you've had this? A few times now? Nice, so if we ask questions, it's just too easy. So, inflammation of the external carotid artery, it's superficial temporal artery. It could extend into the ophthalmic artery and lead to blindness. So your patient presents jaw pain, jaw claudication, headache, scalp, temporal tenderness. They could have visual symptoms, throat pain, right? ESR will be up, treatment, steroids, steroids, steroids. I got a lot of questions on my, I'm not going to tell you guys to always choose steroids, but steroids, consider choosing steroids. I think there's one, I'm pretty sure there's one pathology we talked about where steroids don't help. We talked about it like 2 or 3. We'll talk about it tomorrow, don't worry about it. But otherwise, steroids is a good consideration for my exam, and for really anything that has to do with neuro if it's involving inflammation. But. All right, Marcus gun pupil, the swinging flashlight test, kind of You guys know this one? Okay, boring. All right. So RAPD, right? So you guys know pupils tested individually, dim light with the patient fixating on a distant target. Does all make sense to you guys? Okay. And again, what did we say happens to the pupil when I shine a light into this right eye? What happens to my left pupil?
It constricts.
Good. And remember, it's traveling back. So we have our normal response of traveling back, pretectal nucleus all the way back, afferent, efferent response back forward, and that's going to be where I see a little bit of dilation and reaction. So, all right, this is just an example of it. So now we're talking about both eye visual disorders, so binocular visual disorders caused by either papilledema, a tumor, or other types of lesions. So papilledema, sign of increased intracranial pressure, right? So we have so much pressure in the head that it's pushing out on the eye. Is that a bad day for your patient? Or you, God forbid it's ever you? Yeah, it's not good. So maybe secondary to like some sort of trauma or a mass. So we need to kind of figure out what is going on. Why is this happening? So is it a hypertensive emergency? Right? Have you guys talked about hypertensive emergencies defined as?
Organ over 180.
Oh, God. Yeah, good. So greater than 180 with end organ damage. Nice, nice. Right, intracranial mass, impaired CSF, or you could get idiopathic intracranial hypertension. So headache, right? Like you're going to get a headache if your brain is trying to herniate through your eyes. That's kind of strange to think about that, but you're probably also going to get nausea, vomiting. And then it says other neurologic dysfunction. Yeah, because depending on what's going on and what we're affecting, you could have swelling affecting other parts of the brain as well. So you could get enlargement of the physiological blind spot, and then also a cranial nerve 6 palsy. It's probably going to be not something we snuff out initially. Most likely they're going to be headache, nausea, vomiting, potentially other neuroscience. So you guys like that? Does that look normal?
Sure.
If that looks normal, does this look normal? All right, the next, so I'm not giving you guys a test question where it says like, which grade papilledema is this? What I'm trying to show you guys, for us when we're out there and in the clinical context of a patient with a headache, nausea, vomiting, and we're concerned about trauma and or some sort of mass or something, this is like a gradual pendulum showing you like grade 1 papilledema, which is minor, all the way to 6, which is pretty obvious. Like 6, Ray Charles could see it from across the room when I show you guys, right? But 1, I tell you guys, if you're not seeing anything outside, it says there, hallmark is the C-shaped halo within the temporal gap. I don't know, it looks pretty normal to me, right? So, grade 2 is the halo becomes circumferential. So, I mean, you can see that something ain't right, something ain't right. Something isn't right around the, you know, that cup, right? So it looks a little obscure and blurry to me. Grade 3 is loss of major vessels as they leave the disc, okay? So again, that looks kind of, to me, a little bit better than 1 and 2, but maybe you're still not appreciating it. 4, okay, hallmark is the loss of the major vessels on the disc. Okay, so if you guys look in a patient's eyes and you see that, is that a concern?
Yes.
Yeah. And then 5, what's the cup to disc ratio? Are there sharp margins? Do you guys see anything? No. So I think I said 6. 5 is this. So it's graded 1 through 5. I just added another one. So, but again, I don't. So this is total loss or obscuration of all vessels on the disc, and we should be able to at least kind of look at this with our patient in front of us having headache, visual loss, you know, nausea, vomiting, and you can't stop puking all over the place, and you're like, yeah, something ain't right here. So that is going to key us to do what?
Send them to the ER.
Send them to the ER, and or if you're in the ER, yeah, like opto ASAP, but neuroimaging, right? Check that dome piece, make sure there's nothing going on in there. There's a bleed, massive massive hemorrhage or mass effect or something like that. Something is shifting, causing that to protrude outside the eye. That's a bad day for the patient. So. All right, pituitary tumors. So there's functional or functioning and non-functioning. So for your functioning, functioning tumors, just think of really do you guys remember the hormones affected by the pituitary gland? TSH, good, yeah. There's a couple other ones, but so what's galactorrhea? Yeah, discharge from from like breast discharge. So amenorrhea, acromegaly, so like HGH, your menses, like those all. So for your functioning pituitary tumors, those are going to mess those up too, right? Because that tumor, that pituitary tumor has some sort of involvement in those systems and is either hyper or hyposecreting, which is going to cause a problem. So for your non-functioning, right, those are not going to be bothered. So you're not going to get galactorrhea, amenorrhea, acromegaly, or you're just going to get visual changes. So that, I don't remember if you guys remember the young lady I had. I told you she was, I gave you a picture of her CT, but she was 30 and she had a pituitary adenoma that was non-functioning because it wasn't affecting anything else. But so if you have a tumor that's growing on that optic chiasm, remember going back to those first couple slides, how's it going to present? Usually that bitemporal hemianopia, right? So they're going to lose those visions on the temporal side. So best eval through an MRI. So we were able to find it with a CT, but she probably would benefit from an MRI just to get better staging and or planning for further treatment, which would include, what do y'all think? You got a tumor in your pituitary gland, you want to get it out? Yeah. So surgical excisions versus drugs, right? So that, and again, the drug decision is going to be based off your patient, right? So some of these drugs can cause like infertility. So you want to, and I'm not going to ask you guys these drugs. I think you may have already had them, but bromocriptine or carbergeline. So these can be kind of tough, but if you can suppress and shrink that tumor to where it's not affecting that pituitary axis, that's fine, right? Then they can live like that. All others are just going to be surgically removed. They can, apparently they stick a chopstick up your nose. I'm just kidding. That's that transpenial resection where they go in through the nose. And I think I may have mentioned the one that I found, I called neurosurgery. Neurosurgery was like, hell no, call ENT. And ENT was like, nope, I'm not touching it, call neurosurgery. And I'm like, y'all need to figure this out, like a couple grown-ups. Because I'm not going to do this. Like, I don't have my chopstick set today, so, but. All right. Everybody doing all right? All right. So other binocular visual disturbances, occipital cortex lesions. So we said many times that the back of the head here, the occiput, is going to be responsible for interpreting and responding our vision, right? So any trauma, tumor, infarct, the posterior cerebellar artery could cause a homogeneous hemianopia. But remember when I said you guys kind of fall backwards and smack the back of your head and it disrupts your vision? That's kind of what we're talking about here. Specifically trauma, and depending on how bad you got hit, it could last transiently or it could be permanent. So, or how big the tumor is and where it's growing. So that picture on your bottom right, there's some bleeding in the back of that guy's or girl's head. So it's probably not a good day for them. So cranial nerve 3. So cranial nerve 3 palsy, down and out. So you get a diplopia, ptosis, fixed position of the eyeward downward and outward, and then also dilation of the pupil. Okay. New onset cranial nerve 3 palsies with pupillary involvement. We got to rule out an aneurysm, cerebellar artery aneurysm. We got to look for trauma, meningeal inflammation, tumors, or again optic pneumonia migraine. So we need to make sure this person isn't having a bleed internally or some sort of mass that's causing this palsy. So what was I going to say? Man, I'm forgetting a lot of stuff today. But this is just showing the muscles from the floor. So looking from above, excuse me, so we're looking down at the eyes. So again, just how do we find these palsies? Well, we look, because the next picture is going to show you, if you see this guy, aside from looking like he has acromegaly, what's going on with him for you guys? So which eye's jacked up?
Right.
His right eye, so it's completely not open, right? So this patient comes in and he was just in some sort of trauma, right? He just got blown up. Are we concerned about something in here?
Yeah.
Yeah, absolutely, right? He can't open his eye. I mean, you can see there, I don't know if that's his own hand or his, maybe it's his PA's opened his eye for him, but this is a crap picture, but you can kind of tell if you hallucinate enough here, like his pupils also dilated out a little bit, so that's not a clear picture. Don't hang your hat on that one. So this guy, so again, right eye, say, hey sir, like open your eyes for me. Okay, something ain't right here, right? So now I'm opening him, and I see that right eye is down and out, and I also see his pupil is blown a little bit. So we'll talk about anisocoria in a second, like the difference in pupils that can be normal, right? Physiological anisocoria, if your pupils are like 0.5 millimeters difference and that's how you've been your whole life, am I super excited about it? Nope. If this guy came into me and was just kicked in the head by a donkey and was like, now this is going on, am I worried about it?
Yes.
Yup, 100%, right? I don't know why I'm coming up with these weird, like, who got kicked in the head by a donkey, I have no idea, but does anybody know who Rodney Dangerfield is? That kind of looks like him to me. I have no idea why that is relevant, but just based on the eyes, and I can't prove or disprove that it is or it isn't. So. All right, anisocoria, so asymmetric pupils, sometimes it's fine. If it's congenital and it's 0.5 millimeters, right, up to 0.5 millimeters, you don't really care. I would imagine somebody in this room has this, but, and then sometimes it's not fine. So how do you know the difference between the two?
Over 5 minutes.
Perfect. Did you have it before? Is this a new finding for you? Are they coming to see you? Like, what are they coming to see you for? Like, is there other symptoms associated with it? Like, what are some other symptoms that would be concerning? If I had a blown pupil, headache, nausea, vomiting, intractable, right? Like, I gave you some antiemetics and you're just puking even worse. Loss of balance, any neurological finding, right? Maybe their eyes down and out too. All right, algorithm, well, a lot of medicine is algorithmic. Really, this is just showing us when we need to be concerned, and I'm just going to summarize some of this. I'm not going to ask you guys questions, but so history of trauma. So it says patient presents with anisocoria today. A history of trauma. It says you can check the old photographs. Good luck with that. Use of topical medications, exposure to toxins and drugs, and then other associated ocular or neurological symptoms, right? And you guys can follow this down. When you get out and practice, do not memorize this. But I'll give you guys a pretty neat case I had. This lady came in, she was a nurse. And have I told you this already? If I did, just tell me to shut up. Did I? You don't know yet? Because I haven't even said it. So she came in and had a unilateral anisocoria. She was at work, and her coworkers were like, you need to go to the ER, like your pupil is blown. And she came in to see me. She had no symptoms whatsoever. She's just like, I don't know why it happened. What do we do in the ER? Yeah, 100%. I'm like, are you having a stroke on me? So neuro exam was completely benign. So I did an NIHS, which we'll talk about next block. I looked for nystagmus. I did my visual fields. I did my X-ray ops. Completely normal. Her pupil was like 2 to 3 times the size of the other one. It was reacting. It was accommodating. They were consensual. Like everything looked fine. And I'm like, something doesn't make sense here. So blood pressure was great. But I got some baseline labs on her, and I did a CT of her head, which was normal. Get called back in, gave her some, she tells me like halfway through her workup that she's feeling, fatigued and lightheaded. So I'm like, give her some fluids and some antiemetics. Just keep an eye on her. Blood pressure started to go up a little bit. Workup was completely normal. So I'm like, I need to talk to an ophthalmologist, just see what's going on here. So. The only thing that was weird about this lady is like a week before she had been diagnosed with a bacterial conjunctivitis and given Polytrin, which is like a completely normal antibiotic that you would use for conjunctivitis. Anyways, I talked to the ophthalmologist at university, and he was like completely underwhelmed by it. He's like, "Yeah, it's cool, man. I'll see you tomorrow." And I'm like, "I don't know, sir. Like, how do you spell your name again? Like, let me just make sure I spell it correctly in my note." But long story longer, he found out through her that she is also using Visine. Which, how many people use Visine drops in here? Probably a lot of us, right? So for dry eyes. But the Visine had a component in it that was reacting to the antibiotic and causing a unilateral anisocoria. Why it was happening in one eye and not both, because she was using it in both, I have no idea. But again, it was a weird case. And if you guys follow this down, you would find that pharmacologic anisocoria on the right, all the way at the bottom. But I was busting through algorithms like this. I was talking to my attending, and he's like, yeah, we need to get her to ophthalmology. Like, that's impressive. And I'm like, yeah, yes. All right, 4 different things to look at here. So you can see there's kind of like 4 different charts in here. It's tough to see, but so this is showing us abnormal anisocoria versus kind of normal. So you look in that first cluster in your top left, labeled A. This is your normal pupillary reaction. Both pupils are symmetric in the light and dark. So I don't know if you guys can appreciate that. But then you move to the right, you see B. Small pupil is abnormal. The right pupil does not dilate well in the dark. And this is just giving you guys don't have to memorize this. This is just kind of showing you for people that are visual learners. C in the bottom left, right, the large pupil is abnormal. The right pupil does not react well to light. And then D is your physiologic anisocoria, where the amount of anisocoria is the same in light and dark, right? So if I had D, and it was just the same, that would be probably reassuring for me, especially if there's something that was, I don't know, maybe it's been happening for a couple of months. Do y'all remember Horner syndrome? So, what is it? Yeah, every class somebody says that. Like, oh my God, I was getting a kick out of it, man. So, just circle the 3 there. So, atosis, meiosis, anhidrosis. So you get the lid lag, pinpoint pupils, and then lack of sweating, right? So lack of sweating. So, okay, and these can be caused by a brainstem stroke, carotid dissection, or you can get like a lung tumor that can also cause this. So you can get a preganglionic or a postganglionic Horner syndrome. Here's the takeaway from this. If the patient has this classic triad, which is what? All right, good. We need to rule out a lung tumor or a carotid artery aneurysm. So they're either dissecting in their neck, which is a problem, right? Or they have lung cancer, which is a problem. So just one of the ones that folks like to ask on board questions, Horner syndrome. Just watch out for, I can't even remember the type of cancer is in my notes here. Just remember for the carotid artery dissection or the lung tumor. I don't even have a specific type here. All right, how we doing? We good? Break? Break? We're good, we're great. All right, a couple more and then we'll end. So I think we'll do a couple more because I think you guys have seen these. Argyle-Robinson pupil, prostitute pupil, right? So it accommodates but doesn't react. I need you guys to forever think syphilis, right? So think that this could be a late finding of syphilis, neurosyphilis, but it also could be MS, multiple sclerosis. I think I had someone last class, it might have been mid-class, tell me that it's like losing favor with syphilis diagnosis, but it is still out there. I double-checked, PubMed, up to date. It's still a late finding for neurosyphilis. And to me, it just was always beat into my head. I always remembered Argyle-Robinson for some reason. I don't know, maybe Little Jack Horner. This thing stuck with me. Was a prostitute who was always very accommodating but wouldn't react to you and had neurosyphilis. So I was like, that's a wrap. So yeah, that's done deal. So 80s pupil is a tonic pupil with parasympathetic denervation. Constricts poorly to light, better with accommodation. Does anybody know who we see this in? What? Huh? Women, 100%, yeah. So older women that have, just go for the hat trick. Just say diabetes and you'll be right. Yeah. So older women with diabetes can develop this too. Let's see here. Tonic pupils are also associated with multiple system atrophy, segmental hypohidrosis, diabetes, and amyloidosis. Or something interesting, but diabetes, I think. So, all right, let's take 10. We'll come back and finish. All right, so where did we leave off? This, right? I'm sure that sounds right. So cranial nerve 4 palsy. What did we say cranial nerve 3 palsy would present like? What is that? Down and out. So what's a 4 palsy gonna look like? Up and in, right? Nice, nice. So patient's gonna come in potentially with diplopia. Could be a common cause of vertical diplopia. Head trauma is the most common cause. Okay, and then we're gonna be up and in. So upward and slightly medial. So I think that's all I want you guys to take away from that at this point. So again, just we go back to this and see it a bunch just to kind of beat this into your cerebellar executive suite there. So all right, so physical exam wise, so you're looking at A. It's, I don't know, maybe you guys can see it. It's kind of tough, right? So the right eye is elevated on forward gaze. Is that subtle to you guys?
Yeah.
To me too. So B, okay, so the extent of the elevation is increased with adduction. So it's still a little bit hard for me to see. C, the extent decreases with abduction, so that looks like it's back to normal to me. And then D, you're doing this head tilt thingy on them. As you tilt, so if you tilt towards the affected side, it's supposed to make it more prevalent, but I don't know, that looks like kind of witchcraft to me. And I'm not really doing this for my patient. Like I'll do head and pulse nystagmus and test the skew when we talk stroke, and I'll have them look forward and kind of do a quick doll's eye and have them look. We'll get there in the next block, but this one's subtle, that's what I tell you. So again, same thing we talked about last time with any real cranial nerve palsy is like, you know, what sort of things do you guys think could cause this? Lesion, trauma, right? So again, we just need to get the right clinical context from our patient. So you guys see there, we'll go to cranial nerve 6 palsies. Again, this is all redundant, but trauma, microvascular disease, which is a stroke, neoplasms, most common, right? See a bilateral cranial nerve 6 palsy could have increased intraocular pressure to improve otherwise, which that could be what? What did we just talk about that causes increased intraocular pressure?
Neuritis.
Papilledema, right? So you could have a cranial nerve 6 palsy with that as well. So it's good. All right, 6 palsy, if you look at A, this is giving you another example. So the affected eye, the right eye is adducted at rest, okay? And then in B, it can't abduct, okay? So how do I figure this out with my patient? Extraocular movements, you look at them, right? Like, I don't know. So I had a patient once that presented with like a simultaneous 4 and 3 palsy, and I just was doing extra ox and was like, how are you doing that with your eye? Like, what are you talking about? I'm like, follow my finger, and their eyes were like one at a time, like doing all sorts of crazy things and not going, and I'm like, huh, so you're a joker, huh? I'm like, all right. And the guy just got out of prison. It turned out to be late Lyme disease. Not my job to figure that out. Like, I'm just like, dude, what's going on with your eye? Spun him, normal. Labs normal. Admitted him to the hospitalist. Neurologist came down later. He's like, who's P.A. Rogers? I'm like, me. He's like, oh yeah, he had grade 5, man. He had Lyme disease. And I'm like, cool. Wasn't in my differential. I'm like, what'd you give him, Doxy? He's like, yeah, very good. And I'm like, all right. iPad. But he was like, did you appreciate the simultaneous cranial nerve 6 and 4 palsy? And I'm like, bro, he had crazy eyes. I don't know what you want from me. Like, yeah, that's how sometimes it happens, but anyway. All right, cranial nerve 5, trigeminal neuralgia, aka tic de la rue, right? Have you guys had this one? No? Okay. This is lancinating pain and the distribution of one or more branches of cranial nerve 5, right? Triggered by touch, eating, drafts, so like light air, not like drafts at the beer or the clubhouse, but like they blow on the person and their face and they're like, ow, like that hurts a lot. So pathophys is a compression of the trigeminal nerve root by a blood vessel. And your ESR, CRP are going to be normal as opposed to, which one did we talk about with ESR up? Giant cell temporal, right? So I think I asked you guys a question on this one. Oh, again, stay tuned for tomorrow. Spot recovery can happen, right? Treatment options. You guys can see there. So these are seizure medications, really, is what they are. So you don't see on there steroids. So steroids, NSAIDs, those aren't going to work. Carbazepine, that's going to be one. But again, it says there, I don't care that you guys memorize agranulocytosis. We just need to monitor their CBCs and LFTs, right? So we need to look at their stem cell production, make sure they're knocking their ability to produce white blood cells out. So, all right. What do you think? Anybody? 7? So is Bell's palsy? Oh, what a crappy picture. It's all pixelated there too. Yeah. All right. So unilateral paralysis of the face, right? Okay. So cranial nerve which? Nice. Bell's palsy. So idiopathic facial paresis of your lower motor neurons attributed to inflammation of the facial nerve, more common in women and diabetics. It's just like AIDS, we just talked about that. Sudden onset, so max weakness by 48 hours. Pain behind the ear may precede paresis by 1 to 2 days, and then they also get loss of taste. So I hate to say it, and at least n equals 1 from what I see this, they usually come in with otalgia, ear pain, loss of taste, and unilateral facial paresis. So yeah, that's what the book says too, so that's pretty neat. So. And what's the big delineator between this and a stroke? Does anybody know? Forehead. So forehead is involved or isn't with Bell's? It's spared in a stroke, right? So it is involved with Bell's. So if you have just Bell's palsy, the forehead is going to be involved, okay? If it's a stroke, it's going to be spared, and that's because it's got concentric supply to frontalis. We'll get there in stroke. Bell's palsy, forehead is involved, okay? And I have no idea why this isn't likely to move forward. This is exciting now. Oh God. Oh wait, is it moving for y'all?
No.
All right, we got this. Let me figure this out. I just had a spinning wheel of death. We were so close too. We're getting there. What do we want to do? Task manager this thing. Whoa. Let's end this thing. Look at all this crap.
Slide change.
Oh!
Natalie, you probably tried.
Oh!
Oh, hey.
Oh! We're back. Now it's gone again. This kind of sucks, to be honest with you. So, it's weird. I don't know. Microsoft PowerPoint is not responding. It's tired. Yeah. Let's try this again. It's borderline unacceptable.
Staff manager not coming up?
What's that?
Staff manager not coming up?
No, nothing's coming up. It's literally just spinning for me. I can't even get out of this. I'm locked. Here, restart. What's that? It's having a stroke, is that what you said? Yeah. It's telling me that it's restarting now. Holy cow. I'll try it again. If it doesn't work, we'll have to figure it out without it. This could be catastrophic. Yeah, we could do that. iPad with no slides? What are we going to do?
I never would have reached. It's too competitive now. Like, I have to get C average. But like they take
75.
You'll be a doctor, but they come on. That's funny.
Well, if you're sitting there and you don't want it to work, say it, bro. It's tough. It's working. Is it working for y'all?
Yes, sir.
Where were we? I have no idea. Let's just start right here.
Yep.
Yeah.
All right, let's start right here and see what happens. I think we just said that, right?
Sir.
Yeah, but look, it's not.
Focus for you.
Yeah, it just doesn't want me to do this, I guess. That's fine. You win, computer. It's crazy. It's just giving me a spinning thing of death. It's not moving.
Can you go back to the non-presentation mode and just?
That might be the next step here. Yeah. I gotta wait for it to. I apologize. Yeah, just bear with me for a second. This is audio. End this program. Anybody got a good joke? Clean joke? No? No? Alright. Alright, Bell's palsy. Here we go. It sucks. You guys aren't going to be able to really see it that well. We're back? Everybody alright? Do we need another break? No? Alright. What did we say about Bell's palsy so far? Anything?
Spares the forehead. Or does not spare the forehead. Sorry, opposite.
It does not spare the forehead. It includes the forehead.
Yeah.
Strokes tend to spare the forehead. Okay. So there, when forehead muscles are spared, we need to think central lesion instead, and or what's kind of synonymous for that, central lesion? Like stroke, tumor, mass, right? So Bell's palsy treatment, about 60% recover with no treatment. Steroids again, right? So protect the eye. So the eyelid isn't allowed to close anymore. That's gone. It's knocked out. So these folks come in, and oftentimes we miss this, but as clinicians, we need to give them like refresh, lubrication drops for their eye to protect that sclera and that conjunctiva. It prevents secondary infection. If it's permanent, right? So sometimes these folks can develop permanent cosmetic issues, right? Send them to who they need to go to. Who do you think would deal with a cosmetic issue of the face? Plastics. Anybody want to go to plastics? Big money in plastics. Yeah, big money in plastics. Nobody said yes? All right. That's bull. I hid some of these, so if they're hidden, I don't want you guys to worry about it. So central versus peripheral lesion on cranial nerve 7. So this is again showing forehead involvement or no forehead involvement. Ramsay-Hunt syndrome, right? So this is this is herpes, re-eruption along cranial nerve 7. So you can get facial weakness just like Bell's, significant prodrome of pain. And then you also get a vesicular rash. So if you're looking at somebody that come in and present like a Bell's palsy and they've got blisters on their ear, right, painful rash, just consider Ramsay Hunt as well, okay? They can also develop nausea, loss of balance. Why loss of balance if it's affecting the ear? Yeah, vestibular system's in there as well. So, and this one's, that picture's kind of tough to see, but you guys can see the presentation of those vesicles just inferior to the auricle, kind of superior to the tragus. You can see some of those vesicles there. So, okay. You don't need it, but you can get an MRI, show inflammation of cranial nerve 7, right? You can get nerve conduction studies showing slow or damage of that nerve as well. And then because it's a reactivation of herpes, right, we could use antivirals, acyclovir, famciclovir, and steroids too as well, right? So we can suppress the immune response, but really acyclovir is going to be our drug of choice for this one. So. All right, cochlear portion, so now we're in 8, right? So you guys remember this from earlier. I would definitely kind of re-look this before Friday morning, just look at you a couple points, but for conductive hearing loss, right, process affecting the external auditory canal of the middle ear, remember that Weber lateralizes to the side of the lesion, and with Renee, you get bone conduction greater than air conduction on the side of the lesion, and then flip that with your sensorineural hearing loss, your Weber lateralizes away from the lesion, and air conduction is greater than bone conduction. Okay? Do you guys remember that? Is that fair? Yeah? Okay. Kind of talking about your tuning forks is when you tell your patient flip the fork or something like that. That's what you'll commonly hear it as. In clinic, you know, my patient flipped the fork, and you just send them to maybe HENT or audiology for an audio program. All right, cranial nerve 9, 10, and 12, right? You guys can see there for 9, diminished gag reflex, disturbed swallowing, 10, asymmetrical rise of the uvula, and then 12, facial paralysis, flaccid paralysis of the tongue with atrophy and speech difficulties. Biggest concern I have for you guys, obviously know what they're doing. We talked about knowing what our cranial nerves do in the beginning of this lecture. But also when you're doing the physical exam, right? So how do I elicit a response from cranial nerve 9 if I'm concerned about it? Exactly. You guys can see it on there. I'm not trying to insult your intelligence, but contain gag reflex. And I've tried to be as truthful with you guys as I can. I've had patients where they were, like it was a Guillain-Barré, rapid evolving Guillain-Barré, and that's one of the things that the neurologist asked me, is like, is the gag reflex intact? And I didn't do it, so I went back and I was like, oh shoot, right? It's probably an important one, especially if you're going to talk to neuro, like, how are the reflexes? And I'm like, well, bulbocavernosus, chromesthetic, everything's fine. What about the gag one, weirdo? And I'm like, I didn't do that one. Let me go check. But fingers were everywhere except their mouth, right? So, all right. What side of the tongue are we concerned about here? Yeah, so the right side, it looks atrophied compared. You can see like the loss of like kind of some of that tissue there, right? So that would be concerning for a cranial nerve 12 palsy. Okay. What about cranial nerve 11? How do we test for cranial nerve 11?
Next stroke.
Yep. Shrug your shoulders, turn your head against my hand, type deal. And you guys can see there some of these pictures just eliciting that test, and also you can see some scap winging and atrophy in these middle ones, and then also some scap winging here and some loss of this muscle tone, so muscle atrophy. So again, we don't expose our patient, we don't see that, right? So that's why if we're doing cranial nerve 11, do we need to take a look at those back muscles? Do we take a look at that? Yeah, absolutely. So shoulder blades, look for winging, scap winging, that type of thing. So. All right, altered sense of taste. We talked about how we all hate cranial nerve 1. That's okay. It should be your favorite while you guys are here, because you get to wave like nice scents in front of each other's faces. There's also other cranial nerves that innervate our taste as well. So. Not going to have you guys remember this, and I'm not going to ask you questions. I would just like you to know that cranial nerve 5, 7, 9, 10, and 11 can also affect parts of the taste as well. So Do I think it's important that you guys know that hot peppers are related to cranial nerve 5?
No.
Not really. Do I think you need to know 2/3 versus 1/3 of the tongue? Not really, and here's why. Anatomically, that's great, but do you think your patient's going to come in and say, I can't taste in the distal portion with the distal 1/3 of my tongue? No, it would be great if they did, because you guys would be like, well, that sounds awfully familiar. That could be some sort of cranial nerve involvement. And when my patient comes in from a motor vehicle accident and they're on a spine board with a seat collar on, do you think I'm popping hot peppers in their mouth? But what does this taste like? And they're like, I don't know. I'm like, why are you doing this? No, I don't. All right. Do we just want to wait till tomorrow? Because you guys can't even see this. This is just, I don't want to waste your time. All right, 71-year-old diabetic male presents to your clinic for his annual foot exam. He complains of stocking glove pattern of burning sensation to his feet bilaterally. Monofilament test reveals diminished sensation to light touch, and he is unable to detect a vibratory stimuli. Which of the following treatments is not appropriate in the management of this patient's condition? So we have A, nortriptyline, B, gabapentin, C, oxycodone, D, venlafaxine, and E, lidoderm patch. How many people say A? How many people say B? How many people say C? How many people say D? How many people say E? Yeah, so you probably don't want to give him narcotics for this. Practice how you want. Press Gini scores will be through the roof. Can you use TCAs for this patient? Yeah, tricyclic antidepressants, nortriptyline is a TCA. Can I use gabapentin?
Yeah.
Can I use venlafaxine?
Yeah.
Can I use lidoderm patches? Yeah.
Yeah.
It'd be weird to have him put them all over his feet, but whatever you want. Can I use oxycodone? Should you use oxycodone?
No.
Fight your fight. You should not, right? Because then they're going to come back as drug addicts with messed up teeth and skin and epidural spinal abscesses. And you're like, what happened? I need more drugs, doc. I'm not. Do you want me to? I'll read it out loud. Why not? 51-year-old female presents to neurology for eval, progressive weakness and sensory loss. Patient reports that she initially had difficulty while walking because she could not keep toes from dragging on the floor. She now uses a walker for assistance to ambulate with a high steppage gait. She also reports increasing difficulty with fine motor tasks like buttoning her shirt or brushing her hair. Different what that's spelled. Right? She recalls her mother remember loss of purposeful movements. All right. She recalls her mother. I was gonna anything to get you guys to say ataxia, but she recalls her mother suffering from a similar disability around the same age as she is now. Physical exam reveals absent patellar reflex bilaterally and atrophy of the lower legs. Which disease process do you suspect? Yeah, like what if I told you it was atrophy that looked like an inverted champagne bottle? Wouldn't you like me a little bit more? Yeah, so CMT, Charcot-Marie-Tooth type 1, right, CMT1. So, cool. You're like, not cool? I don't all right, let's try another one. Let me see if this is a good one. Oh yeah, okay. I think I used this one on your exam. Wait, do I? I think so. I'll confirm tomorrow. 42-year-old female, history of hypertension, presents to your clinic complaining of lancinating preauricular and maxillary pain on the right side of her face. The pain is elicited by light touch and by tapping the maxillary molars. She denies visual loss or photophobia. All lab studies are normal, and fundoscopic exam is unremarkable. Which of the following is the most appropriate treatment for this patient's condition? First of all, what the hell does she have? Herpes? I mean, you just want to give her herpes? Yeah. So, not entirely fair to ask you this because we just talked about it, right? We talked about Lancet, pain, drafts, and I was like, oh, no, the draft, what was that? Yeah, so tic de la Rue, right? Or does anyone remember the other name for it? Trigeminal neuralgia. And then, if you got that, did you remember?
Steroids.
So this one's not steroids.
Not steroids?
This one's not. That's not bad, though. That's not bad. So you may see this one. This may be the only one that I try to button hook you guys with, and I think I give it to you. So don't choose steroids for this one. Okay? No, don't choose steroids. Okay. Good. You can't hear me? You're just telling me now?
It just
Oh, really? Nice. I'm like, what about now? All right, don't choose steroids for this one. So oxycarbazepine is the good choice for this one. So these are kind of weird ones because they're anti-seizure meds for this trigeminal neuralgia or tic de la Rue. But I think I've never really gone over this, I guess. All right, 69-year-old male, history, poorly controlled hypertension, presents to clinic complaining of the worst headache ever. Vital signs, 178 over 110, heart rate 110, respiratory 22, and 99.1. Fundoscopic exam is significant for papilledema. I don't care if it's grade 3. Which of the following is the next step in the management of this patient? So you got a patient in front of you that we've got, remember we said, so we just went over papilledema too. We said it's grade 1 through 5, and I was like, I don't really care. So something is causing this pressure in this person's head to push their eyes out towards you. So what is our first step that we're going to do for this person? CT non-con, right? So non-contrast CT of the head. Okay? Non-contrast CT of the head. Answers in this one kind of suck because the next step in management I want you guys to think about is we need to investigate what's causing that. So we need to get a non-con CT, which is going to take us about 10 seconds, really, because we need to explore if there's a bleed, if there's a mass, or something else. Someone will argue, are we simultaneously giving something to control their pressure? Whatever, I don't care. Maybe. I'm actually not jazzed up about 178 over 110. That's like, if I see that, I'm like, oh, not bad. This is a good day for you, right? If I change that and made it like 220 over 180, right, then I would articulate, I'm probably going to give them something to control their blood pressure, maybe before I send them over there. But for this, non-contrast CT is what I'm trying to get you guys. Do they need an emergent or immediate referral to neuro? Probably. Do I need to talk to ophthalmology? Probably. But what do you think they're going to say? What do you think they're going to ask you? What's the CT say? What are you going to say? I didn't get it because the eyes were popping out of their head. It looks really bad. They're going to be like, "Do your job and call me back," right? So you're going to get excited. And you're going to be like, "I know what this is," but you got to explore and clear your deck before we start getting them energized. Okay? Because they're just going to say, all right, do me a favor, do this, and then call me back, and we're just delaying patient care, which is not good. Is that fair? That was it. All right, tomorrow at 8, right? So we'll do a